Abdominal aneurysm is a ballooning or weakening of the main artery of the abdomen, typically in the segment between the kidneys and where the aorta branches to each leg. The intention of surgery, the surgical objective in the treatment of aneurysm, is to eliminate that risk for rupture. So what we want to do is seal off that weakened segment from circulation. Risk factors for aneurysm would be male gender, senior citizen age group, cigarette smoking. There can be a genetic disposition to it, and you can see it in families. Hypertension and atherosclerosis or hardening of the arteries. So if you put all those, if you have a male smoker with high blood pressure, his father had an aneurysm, you better be screening that patient.
You can see here that the aneurysm is this thrombus that sticks out here. That's the disease. And then the neck is the distance between the healthy aorta, between the lowest renal and where the aneurysm starts. And that's where the top of the graft would sit and these hooks would seed. No matter how much you can form the graft, nitinol has memory and it's going to go right back to the shape that it was heat formed in.
This type of product is crimped down so that we can bring this in a very low profile. So even when you put in a stent graft, the risk of ruptures over time is about 1%. It's not zero, but it's almost zero. Stent graft has been deployed right below the renals, exactly where it needs to be. We don't see any contrast or dye coming around the stent back into the aneurysm. In fact, we don't see the aneurysm at all anymore, which is what we want.
For this case alone, this used to be a 7 to 10 day hospital admission with ICU. Both these patients will go home tomorrow, usually on Tylenol. They don't even need pain medication, so it's a great alternative.